Hello, and welcome back to the STIs podcast. This is season 9, of course, where we turn science into sense. In this season, we provide 10 timely episodes with the hopes of helping listeners understand what we can learn from current research on harm reduction. And let me just say, there is so much here to learn. So, I'm glad you're with us. I'm Danielle Rudes, your host, and this is STIs. In North America, and Canada specifically, there was a sharp increase in the rate of drug overdose deaths between 2012 and 2018. In Canada, this increase prompted the government to declare the overdose crisis as a public health emergency in 2016. Cities in Canada like Vancouver have seen a heavy impact of this crisis, and in response, have attempted to expand and intensify the overdose prevention efforts they take, also known as harm reduction strategies. With this improvement, though, there is still a lot of missing information and data regarding certain populations, like marginalized women, including sex workers. We know that sex workers are disproportionately overrepresented when looking at people who use drugs across the world, and that women sex workers have a high prevalence of drug use. Not only do these women have a higher prevalence of drug use, but with that comes a higher risk of HIV or other sexually transmitted diseases, and bloodborne infections, poor mental health, and mortality. While we know these outcomes, there is not much information on their risk for overdose. Why is this specific group of people important, though? Well, there are gender-based inequalities that shape health and the safety of women who use drugs, and their jobs in sex work can exacerbate these inequalities. There are also structural factors that can influence women and sex workers seeking out help or treatment for substance use. These structural factors are things like criminalization of both drugs and sex work, negative police interactions, and stigma. Police interactions or practices specifically is one area that has not been studied in depth regarding its impact on the risk of overdose for sex workers. In a paper by Shira Goldberg from the Center for Gender and Sexual Health Equity and the Faculty of Health Sciences at Simon Fraser University, Goldenberg and her colleagues looked at the police-related barriers to harm reduction that women sex workers who use drugs faced and the impact on non-fatal overdoses. This study used longitudinal data from a larger study known as an Evaluation of Sex Workers' Health Access, or AISHA. The AISHA is an open, prospective cohort study that took place in Metro Vancouver, British Columbia, from 2010 to 2017. Longitudinal data is simply data that was collected over a period of time, where the same people were included at more than one point in time. Prospective studies fit right along with longitudinal data, as it means the information is collected as it is happening over time, instead of asking the participants what happened in the past. In this case, this means collecting data from women sex workers who use drugs every 6 months over a period of 7.5 years. These interviews with women were conducted by a trained interviewer and included a questionnaire with over 200 questions on various topics and serology testing and treatment for sexually transmitted infections, or STIs. The topic in these interviews, or the topics, I should say, covered things like their socio-demographic characteristics, sex work history, and patterns, and social and community level factors, and structural factors. The structural factors asked about things like interactions with police, as it is important for this study, and other things, as well as workplace violence, workplace environment, and criminalization. For this study specifically, the main outcome variable Goldenberg and colleagues were looking at was non-fatal overdose. This was measured by a question that asked participants if they have overdosed by accident in the last 6 months. The researchers mainly looked at a variable measuring if the participant had experienced any barriers to harm reduction due to police presence. They also looked at things like age, income, indigenous ancestry, mental health diagnoses, minority gender identity or sexual orientation, as well as variables related to drugs and drug use, like the type of drug, the mode of administration, and the frequency of use. In total, there were 624 participants included, as these are the women who reported using drugs during the study. In their baseline or original interview, 7.7% of the women reported a non-fatal overdose in the last 6 months, and 28% reported having at least one over the entire 7.5-year period, which totals 287 non-fatal overdoses. The number of women who had used drugs was much higher, though. Split by non-injection and injection, 61% used non-injection opioids and 63% used injection opioids, while 96% used non-injection stimulants and 54% used injection stimulants. When it came to the main independent variable, over 2/3 of the women had experienced police-related barriers to harm reduction. Since this study focuses on police practices and interactions, I wanted to mention a little more detail regarding some of the most commonly reported barriers that the women experienced. These barriers included difficulty accessing drugs, rushed smoking or injections, police confiscating harm reduction equipment, being jacked up or searched or hassled by police, and police activity resulting in the difficulty accessing sterile harm reduction equipment. Now that we know about the sample, let's move on to the main model Goldenberg used for analysis. The researchers used a multivariate logistic regression statistical model. I know, stay with me. A multivariate model is exactly like what it sounds like. It uses multiple independent variables at the same time to see how these factors influence the outcome variable. A logistic regression is a statistical model that uses an outcome or dependent variable that only has two outcomes, like here, where they were looking at non-fatal overdose and the answers were yes or no. In this model, they saw that exposure to police-related barriers to harm reduction strategies was associated with increased odds of non-fatal overdose. Basically, this means that for women sex workers who use drugs, when they experience police-related barriers to harm reduction, they are more likely to have a non-fatal overdose. The researchers demonstrate that sex workers in Metro Vancouver have a high burden of non-fatal overdose, with police-related barriers increasing the chance of one. The researchers note that even in an area where there is progressive harm reduction and prevention interventions, these barriers and inequalities related to police that impact marginalized women like sex workers can continue to limit the reach and impact of the interventions. So what do we do about all of this? Goldenberg and his colleagues state there is an urgent need to improve harm reduction access for sex workers, and they have suggestions on how to do this. There needs to be sex worker-friendly harm reduction services, and they need to be gender-sensitive, trauma-informed, and peer-led. The researchers even mention one current example that is considered a best practice and can be adapted to other areas. This best practice is the St. James Infirmary based in San Francisco. The St. James Infirmary is a peer-based occupational health and safety clinic that supports care that is trauma-informed and gender-sensitive, as well as provides advocacy and social justice for sex workers. Other strategies that the researchers find promising to help overcome barriers include anti-stigma and peer-led approaches, drop-in hours, mobile service delivery, harm reduction, and violence supports. To conclude this episode, I want to also mention some of the broader structural reforms that are needed. Decriminalization of all aspects of sex work is the largest of these. Another structural reform is to have more progressive policing practices when it comes to sex work and drug use by having non-harassment policies and moving policing practices away from the areas where supports for marginalized populations are located. Thank you for listening to the ACEDIT podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write to me, Danielle Rudes at Sam Houston State University. My email is drudes@shsu.edu. And of course, thank you to the Justice Community Opioid Innovation Network, or JCOIN's Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters, Dr. Alyssa Toman from Texas State University and Sam Houston State University doctoral student Caitlin Bauer. And a huge and heartfelt thank you to Jason Luchin and the team at Slonky LLC for their spectacular production. Tune in again soon for another episode of Aced It.